So it's interesting that, and I'm going to go back to the slide you showed with that young girl. So Frankel actually was the first guy to describe this. And if you go back to Frankel's paper in 1969, he actually followed a thoracic complete patient and watched the paraplegia go up the guy's spine over and over. So when I started my practice 15, 20 years ago, we had much more commonly, we'd see these kids, what we called ascend. And it only happened in the complete patients. And so I published them, 60 patients, Asia A, and 6 of them actually got worse within 40. Usually doesn't happen on the first day, which is also kind of interesting. Usually operate on them, it usually happens 20 to 48 hours later. And the only thing I could pull together with those 6 patients were what? They were all young, they were all males, which kind of doesn't count because 80% of patients are males. Uh, they all had hyperflexion injuries and they all had sustained hypotension during their stays, which was kind of interesting when you looked at it. So, as Brian said, it's very interesting. And when you go and you look at the axial films of that girl, and when I looked at mine, the most amazing thing is the spinal cord is like 2.5 times bigger than it should be. And it goes back to your question is, are we, are you hyperperfusion the spinal cord at some point because it strangles it off? And that goes back to your question with Papadopoulos and doing duroplasty. There was a paper written a while ago about thoracolumbar fractures where I did the review and I think I rejected the paper. And if someone else wrote it in here, I'm sorry. But what they said was kind of interesting. They said in thoracolumbar burst fractures with neurologic injuries, the people with CSF leaks had a better neurologic recovery. And it kind of didn't make sense to me at the time because I'm like, well, wouldn't you rip a nerve root or whatever? But their hypothesis is that your hypoperfusion, once you lose the CSF pressure, you probably you perfuse the spinal cord better. Now, let's step back for a second. Who's a neurosurgeon? You guys all neurosurgeons? So who gets the hated call from the cardiovascular unit? You've all gotten it, right? Mr. Smith had a AAA and he woke up paraplegic. And you're like, oh shit. And they're like, oh, his INR is like 700 and we want you to put a lumbar drain in. And you're like, great. Well, get an MRI because you know they're not going to take the wires out their chest because that's going to take 2 or 4 days and they'll never get the MRI. So you tell them to get a myelogram and then the radiologists say, we'll never put a needle in him because his INR is too hard. Came back to me is if you go through the thoracic literature, if you put a lumbar drain in people getting aortic bypasses, they do significantly better in terms of their paraplegia rate, right? It's not even a question. The thoracic literature is black and white on this thing. So I reviewed the literature and I said, oh shit, now I'm going to end up having to put lumbar drains in all these patients. So I came home one day, again, young guy goes in there, I think he was a drug addict, got a thoracic aneurysm from a dissection, put the lumbar drain in him, and the guy went from paraplegic to moving his legs. Lumbar drain got clogged, and then he went paraplegic again. Fixed the lumbar drain, and this went on for a couple of days, and then the kid actually got his leg function back. But it was one of the most dramatic things to me. And if you think about it, why does that work? You're probably, instead of increasing the arterial pressure, you're dropping down the venous return. As neurosurgeons, we do this what? You put the patient's head up when they have a closed head injury. Why? Because they get better venous return. And so it kind of makes sense that if you're dropping down the CSF pressure, you're probably giving them that couple millimeters more of perfusion. Just to go back to your statement, it might not be huge numbers that we're talking about needing that. So why am I talking about this? Because one of the interesting studies, if you got Twitter or freaking Facebook or any of those social media things that I don't have, is you've been tweeted out about in vivo therapeutics. And and I'm actually in this study, and I'm sure some of you guys are there. Does anyone know what in vivo therapeutics is doing? Anyone? Bueller? So, so, so in vivo therapeutics is an interesting thing. Thoracic complete patients get an ultrasound hyperacutely within 72 hours, open up the spinal cord. Kind of weird thing. They open up the spinal cord and they put a scaffolding in there. Now, 2 things are kind of interesting. One is they've done about 6 patients, but their neurologic recovery rates are a little bit better than you would anticipate. For 2 reasons. One is they're better than they're anticipated early, and 2 is there's no freaking way a nerve is growing through that graft within the first couple months because that would take a year in order to get neurons to be going to the graft. So there's some belief, to going back to what Brian's saying, is are we opening up the cord and allowing the intercord pressures to drop? And that's what Theopolis and that's what these other people going. There is a study done a couple years ago in rats where they actually did do this. and they looked at rats and they didn't do durotomies, they did myelotomies, opening up the cord in order to expand it. Because if you've ever seen a tumor in a spinal cord, it's really stretched out. You open it up and it expands a little bit more. And it's the same thing, why we do, if you believe in doing skull decompressions for cranial traumas. So there is some thought that PIA may be too constricted on the patients, and opening up the cord might do two things. One, allow the neurons to have room to swell. Two, get better pressure in there. And the third thing that's kind of interesting is most spinal cord injuries have a necrotic center on the area where they're injured. And what is that? It's probably not a good thing. And if you open up that necrotic center and let that stuff out, it might be better for the local environment in order for the neurons to live. The second thing I wanted to say on Brian's talk is, Brian, it was 5 points in the NASCA study for neurologic recovery. And I would tell you that if you are a C4 or 5 tetraplegic, that is a big deal. And so one of the things we just did is we just had a system going back with guidelines, and we actually had a tetraplegic person in the room. And so we were talking about steroids, and we had a group that was statisticians, and they said, listen, not statisticians, the NASCA studies are the single best studies done by spine surgeons in the last 25 years, which is kind of a powerful statement for someone who has no skin in the game. They're not a neurosurgeon. They're not an orthopedic surgeon. Interesting thing. Two is the whole thing about it being a retrospective review and changing the a post hoc analysis is somewhat BS, because if you go back and you look at their NIH grant that they put in for it, they did say that they were going to do it based on timing of the study. So I actually think, and I'm not a, hey, I love steroids guy, but I do think it's an option, sort of just like what Brian said. And I think the jury's not out on that. And the second thing is, and this is sort of what my talk is, all spinal cords aren't equal. Central cord injuries are totally different than the 17-year-old who's got an Asia A injury in the operating room. Most central cord injuries, I don't know if you have to give them steroids. And why is that? And Brian showed that slide, and I don't know if you guys remember it, but it was kind of interesting. The problem with central cord injuries is what? It's called the ceiling effect. You can't get better. So in order to be a central cord injury, your hands are weaker than your arms. Most of these people are, out of the 100 points, they're 75 to 80s. So they're never going to get to 100. And so they get better, and it ends out. All right. I think that's all I had to say about Brian's talk. Oh, last thing, the Staskis talk. And we'll go through this too. Brian was comparing about how the Staskis early and later wasn't done. And I'll talk about that a little thing. The thing I think we haven't done is step back and look at where have we done in conversion rates over the last 25 years. Because if you go to Ralph Marino's stuff in the 1990s, it was 1 to 2%, 1 to 5% of the spinal cord injured patients converted. And now we're up to, in some of the studies, 70% of the patients in the macrophage studies actually improved or converted. My disclosures really shouldn't impact anything. So I was asked to talk about central cord injuries. Obviously, Brian and I got the same email. But how we're going to break this up is I'm going to go through timing of surgery. We're going to look at animal data, the literature review of this, Staskis, and then we're going to step back and we're going to go through central cord injuries, because I think central cord injuries are a different animal in some aspects than other spinal cord injuries, and really no one knows how to treat them. Again, we all know this. Usually it's a disease of men. Spinal cord injury, 80% men versus women. The interesting thing is when you look at it, I don't have my thing. When I was a resident, it was all 20-year-old people that were having spinal cord injuries. Nowadays, at Jefferson, our numbers are drastically different, and most of the people are my grandparents' age that come in for spinal cord injuries. So you're seeing a lot more central cord injuries. And I'll go through that. I just want to step through and go through a real quick case. And this is your classic case. 67-year-old woman. She fell going over a rug. They usually, if you go and talk to them, they kind of stumbled over something. And I think a lot of the central cord injuries have a baseline myelopathy before they get their central cord injury. And that's why they trip and fall. And it's interesting, if you examine them, you don't get that much tone the first day you meet them. So a lot of these people are really rigid or hyper. And it's funny, the residents are like, the guy's got normal strength. And you're like, no, the guy's got no strength. He's just got so much spasticity and tone, you can't break him. So it's important to try to pick out that difference because, and this is even in your clinical practices, the worst patient is someone with a lot of tone. Because what happens is they a lot of time are functional because they use that tone, and then you operate on them, and they don't have that tone, so they come back to you and they're like, "You made me so much weaker." So I really talk to those patients ahead of time and try to explain to them what the deal is. So what do you get with a central cord injury? You usually get your hand intrinsics are the worst. Why do you think your hand intrinsics? We'll talk about that. Why do you think your hands are the worst? Anyone know who Bungie is from Miami? Huh? Tell us. It's a wife and a husband. They did the Schwann cell trials. He's a pathologist. He did a lot of the things in going through his probably our understanding of the tracks in the spinal cord injury are not correct. And I'll give you a slide on that. Or probably it's oversimplified. But anyways, the hands usually get worse in the week, probably because you have more representation to your hands than other areas in your body. They usually have normal rectal tone. They have some decreased pinprick. A lot of times they get dysesthetic pain. I mentioned the guy Datuno a little while ago. He also told me something I thought was very intelligent. He said, if they have that dysesthetic pain, if you operate on them early, they tend to get better faster. And he thought it was more of a nerve root problem rather than a spinal cord injury problem. And so one of the reasons, if you have really bad burning hands, I tend to hyperacutely operate on those people because I do think it gets some of their dysesthetic pain better. So here's this lady's MRI, her CAT scan, and there's her MRI. A little bit of a blurrogram, but very bad stenosis with large disc. And I think I have a couple questions. All right, here you go. So, and this lady just came into the emergency room. She's 6 to 8 hours out. Would you, and you saw her exam, wasn't that bad, so we'll give her say she's a 90, 94 in terms of her motor score out of 100. Some slight weakness in her hands. Would you let her get better? And this, when I was a resident, the thought was let them get better and then operate on them when they get better. 2, would you put her in a collar, wait 6 weeks to operate on them? 3, would you'd never operate on them, you'd let them treat them medically. 4, operate within 24 hours. And 5, operate within 2 weeks. So you guys have just hit the number you want to do. So it's interesting. When I started my practice, my first big contribution to the world, I said, I am going to do a prospective randomized study on central cord injuries. Right? I said, that's easy. I'm going to solve the problem. It's going to be greater than the world. And I've talked to Bijan Arabadi, who also has some interest in this, at Shock Trauma, tried it too, and Chris Shafferty tried it. And you guys, anyone read my paper on it? You didn't, because it got shot down to hell. And I'll tell you why it got shot down. I'd go into the people and I'd go, how are you, ma'am? Sir, you have a central cord injury. We really don't know if we should do it early or late. And so we want to randomize you, and you're either going to get early surgery. I'm going to put you in a collar, and in 6 weeks we're going to operate on you. And so it went like this. Every little old lady said, well, if they're equal, there's no way in hell you're going to operate on me. And every young person said, well, why the hell would I wait around in the collar for 6 weeks, operate on me now? I don't want to be randomized. And I couldn't randomize any of the patients. All right, so the good news is my talk is over. So most people said operate in less than 24 hours. And it's interesting, we used the 24 hours, and I think Brian is kind of right. It's sort of a made-up number after the Staskis things. Yep. And we'll go through this. We're just switching over. Yep. All right. So it's interesting, just going back now we're going to step back and talk about the timing of surgery. It seems pretty obvious to everyone, if you have a stroke, you want to be in the emergency room and you want to get TPA within 3 hours. I think that's the answer, isn't it? Shiv? Is that what the answer is? Okay. It's been a long time since my oral boards, and I don't have to know that anymore, so I don't. So, and every patient out there, if you stop someone on the street and says, well, how fast if you have a stroke, what do you have to do? And they're like, I got to get to the emergency room. However, you say the same people and you say, hey, you got a spinal cord injury, there's a perception that, yeah, you can do it whenever. And we did a paper in Philadelphia, or not, in Pennsylvania. We looked at all the trauma centers. So we have a regional trauma center, and we published this in I don't know what journal. But we looked at it, and we said, okay, let's see how the ER doctors and the outside doctors respond to a spinal cord injury. is this something they send quickly to the hospital, or is there something they say, well, I'll go home and I'll have my breakfast and then I'll send the patient later in the day? And it turns out spinal cord injuries are the last patients with neurologic diseases in priorities to get sent to a tertiary care center. The average rate was 10 to 12 hours patients sat in an outside hospital before they got sent to a tertiary care center. So one of the things is, if you got these patients, and why is it important? And Brian can tell you this, and all the rest of the guys, is most of the studies now for spinal cord injuries in terms of treatment, pharmacology things are dropping down that they want the drugs in between 8 to 12 hours. And the answer is it's probably sooner is better. So Riluzole, the timeline is 12 hours to get that drug in, otherwise you fall out of the studies. I mentioned this earlier, but I'll just say it again. This is our numbers looking at our spinal cord injury center going back over 20 years. We had a 300% increase in geriatric patients, meaning over the age of 70, showing us the world is definitely changing. And again, just going through, we all know about the spinal cord injury when you get hit by the car, and what we're talking about is destructive or the secondary injuries. So now to switch gears a little bit, Schneider, anyone know Schneider? Jens, I think you went to school with them. Remember Schneider? So Schneider's a central cord injury guy. He's at University of Michigan. What was his conclusion about central cords? Shiv, you never should sit in the second row. Operative or not? He said, do not operate on him. Why? Because he trashed them. And why did he do that? He went in, and how he operated on him, did a laminectomy, opened up the dura, which is kind of nice, which might have been nice, cut the dentate ligaments, moved the cord out of the way, and then cut the disc out transdurally, and then put it back. And the people's spinal cord, you can imagine, you got a mean, angry spinal cord, you don't like that. And that's exactly what happened. Half of his patients had fracture dislocations, which might not have been stabilized because we didn't know that much about biomechanics back there. And so the patients did horribly. A large number of them died. And since then, his conclusion, which is actually interesting, is you should not operate on central cord injuries. So we've come a long way from there, and these are some of his pictures from his paper. The interesting thing I wanted to talk about is, again, this is our understanding from Netter and medical school of what the spinal cord looks like, right? Nicely organized. This is Schneider's with the central cord injury. That's why you lose your hands and not the feet. What happens if I cut the corticospinal tracts with a monkey? Can they walk? They don't have a problem. So this whole thing about, it's all your corticospinal tracts probably does not apply in humans. This is Bunge's paper, where I talked about before, where he did this is a patient who died, a central cord injured patient, and these are the neurons that are dead inside the spinal cord. Interestingly, doesn't fall out into the corticospinal tracts. It falls out over the entire spinal cord, suggesting that maybe your hand fibers are more sensitive to spinal cord injuries, and that's why you get more of a central cord injury. The interesting thing is also if you look at where you get an injury, if you see a patient with a C2 hyperextension injury, they tend to lose their deltoids. And so I have a couple patients where I was writing a series earlier where I was looking at different levels of their injuries and what their neurologic exam is. So it might not be as easy as what we think it is. All right. So Bose actually was from Jefferson, and when I was a resident, the big question was, should you operate on these people or should you treat them medically? There was no questions about surgery or timing of surgery. We've sort of gone on from that, although I will be honest with you, the literature from that is not that great. And I think one of the things is we've become a lot better surgeons in treating papers and keeping people pressurized and using monitoring and understanding the biomechanics of the spine. Brian actually mentioned this paper. I'm a little older than Brian, so I'm going to go back to Tater's paper. So Tater was actually Mike Failing's senior mentor. And what he did is he asked the exact same question that Mike Failing's asked, but he did it 15 years earlier. And what he found out is the average age, what do you think the average time to operate on a spinal cord injured patient was in 1999? The mean time was 8 days. So they used to wait 8 days with a patient in the hospital with a spinal cord injury before you operate on it. So Michael went through and asked the same questions. And this paper is kind of interesting, and Brian hit it But the interesting thing to me about the paper is, yes, people are operating a lot earlier now, but we still have this idea that there's a difference between Asia A's and Asia B's. And to me, the guy that probably got the most to gain from early operation is an Asia A for two reasons. Brian's 100% right that the neurologic exam is probably the best predictor to outcome. But when is a neurologic exam reliable? The guy named Anthony Byrne tried to look at that question, and he showed that it takes 2 weeks to get a reliable neurologic exam that you can predict prognosis. So we're somewhat blinded in the first 2 weeks when we're trying to figure out what to do to these people. And so from my point of view is I tend to be very aggressive with the Asia A's because I'm like, if there's any population that's got the best chance or it's got the most to lose by weight, it's them. All right. This is the Staskis paper. We'll get into that 1 second. So, life's a pendulum. Things happen and you go the other way and now you come back. If you go all the way back to Galen's time, Galen actually was a physician and in the ancient Roman times, they found out that guess what? If you had a spinal cord injury, you did better with immobilization and traction than if you didn't. So what do we know? And I'll blow through this stuff pretty quickly. My time is up. But with the animal studies have definitely shown that the earlier you operate, the better. There's another great study in Plus One if you want to look at a meta-analysis. And again, someone said it earlier. When you have no data, put it in a meta-analysis because it sounds so much better when we say, hey, yeah, there's a meta-analysis on this. And then I don't have to argue when you go, Jim, every study is a class 7. So same thing with animal models here. The problem is, again, animals aren't humans. This is the early surgery data from Michael Failing's group where he looked at, again, a systematic review. If you're a hospital administrator, early surgery makes so much sense. Why? Because if you ignore neurologic recovery, we know that they get out of the hospital earlier, they get out of ICU earlier, and they have less complications if you operate earlier. And the problem is one of the things, if you do a meta-analysis, the definition of early changes. It used to be 5 days, 72 hours, and now we're talking about less than 24 hours. And I'm going to tell you, probably in our lifetimes, we're going to be down to 6 hours to 8 hours. Or at least I think there is. And I'll go through this, but really this is a study. This is one of the classic meta-analysis by La Rosa, where they looked at the central cord injuries, the complete injuries operating early versus late. You definitely got an improvement if you operated on them early versus the late patients. And the same phenomenon is seen with the incomplete patients. Michael's study, again, I happen to be lucky enough, and then Brian was involved in this, but the Stasis study, it is what it is. It's a prospective cohort. It's not randomized. And what we did is broke them up into two larger groups. It's an early versus earlier study. And that's one of the points when Brian pointed out there's not a big difference. You got to remember, this is 14 hours versus 48 hours. No other study at that time had the late group at 48 hours. They had it much greater than that. And again, what were the differences? Kind of interesting. I don't know if this showed up. The three big areas of interest were ages. The early group were younger, which is good for the early group. They had more Asia Bs in it, so that's good for the early group. And interestingly, steroids was somehow involved, and I'm not really sure how it was involved. And Brian said this, so we can skip over it. The patients tend to do better not in getting one level, but getting 2-level betters. So again, if you're in Asia A, your best chance is early surgery to get 2 levels. If you're in Asia C, you're not going to go to an E. So does it really matter if you operate on earlier? I guess you could argue that if you're in Asia C or in Asia D, you have that ceiling effect of you'll probably be pretty good and you don't have that larger window to change. So, and the approach to central cord injuries sort of took a change in the early 90s, in the late 90s and early 2000s. And the first question, and this is what Sontag and the Barrow guy, Chen was a resident at Barrow. What they found out is you could do it and it was safe. And why is that important? Because there was a guy named Larry Marshall that published a paper that said if you operate on these people within the first 100 hours, they tended to do neurologically worse. And I think that's one of the reasons that we didn't know about blood pressure and helping the spinal cord. And where's Jen? Jen's going to love this. When I was a resident, I actually used to operate with the orthopedic guys, and not to trash the orthopedic guys, But Mark, you can defend them for this. But one of the philosophies was that you drop people's mean blood sugar or systolic pressures to 50 because it cut down on bleeding in the operating room. And kind of seems ridiculous as we say about today when you're talking about the spinal cord, but it was actually believed in the 90s and 2000s. So that was one of the big changes. So the second thing comes in, and the Yamazaki is probably a study we'll step in and take 2 seconds on since I'm over. We did write a systematic review on exactly this, looking at the timing of surgery, and particularly in the central cord injuries. Long story short is not many good articles, 9 articles total. And what they did show, I'll skip over this, is basically 2 good papers or decent papers came out of this. This is Brian Lenahy's paper that Brian Coe talked about. And really what it did say is this is the Staskis group. They pulled out the central cord injured patients. And what they found out is that if you operated on them earlier, less than 24 hours, they did better in 2 things, their ASIA, but also their FIM. So their FIM is more of a functional important, which is important. And also no one did earlier. So what they recommended is that you should do it. It is safe if you do it earlier, and you should consider it an ASIA C or below patients to operate earlier. ASIA D patients, they figured they didn't really come up with as strong of a conclusion. The second paper, just really to go through, was another paper, and nothing against the literature, but again, not a great paper. 47 patients, retrospective review, non-consecutive. But the interesting thing is if you take a second and look at this graph right here, this is injury to surgery, right? So this is days after surgery, the further you go to the right, and this is the recovery rate. So you want to have good recovery rate, and you can see as time goes along, your chances of getting a recovery rate are down on these central cord injuries as you live. There's a guy named Penrod, who looked at central cord injuries and showed something else. Is if these patients went to rehab, and he was a rehab doctor, he watched them and they get better. You get better. I mean, if you watch the central cord injuries, they tend to get better. But what happened in rehab is they tended to plateau and then they tended to deteriorate in rehab, suggesting again, you probably, if you're going to operate on it, it might be better to do it earlier. This is some of the statistics from the paper we just talked about. And long story short is the recommendations from the guidelines follow the 2 big papers that Brian talked about is that probably the literature shows that it's good to operate on them less than 24 hours, but you should consider early surgery for the patients, meaning less than 2 weeks for better neurologic recovery. So with that said, we'll go back to the case presentation. Or maybe we won't. Our AV guys in the bathroom?
Andrew's right there.
All right.
Distracted her.
All right, with that, we're done. By the way, we don't have to be done because you guys all said you'd operate within 24 hours anyways.